name is Barb and this is Rhonda.
Welcome to The View. Let's talk a little bit about eyes. So today we're going to be talking about the corneal staining of the eye. This is usually done diagnostically in the office. We use a sodium fluoride and fluorescein, pardon me.
Yep.
The sodium fluorescein is very commonly referred to as fluoresce and or just staining. It's a bright yellow drop. It does have a topical anesthetic in it that numbs the eye as well. And we use this every time we do applanation. But this is not just for pressure checks. It's a great tool for evaluating the integrity of the ocular surface for the tear film. And what does that mean? That means that the front surface of the eye with a normal stain should look smooth. There shouldn't be any strange coloring of the fluorescein stain. It should be a pretty bright green that you see.
Shouldn't see a lot of breakup. You know, it should just be just a nice green.
Should hang on the front surface of the eye, but you should not have any pooling, and it shouldn't be too thick or too thin. Know what you're seeing.
Yeah, take a look at it. It's such a great tool, especially based on what the patients tell you their complaints are. You know, they'll complain of that their eyes are dry, they itch, they hurt. You know, and it's such a good tool to be able to see, you know, what could possibly be causing that.
There's a lot of people that are completely asymptomatic and say that they have no problems whatsoever. But you put that drop in, it should sting a little bit. It shouldn't be a horrible stinging. Some people who are extra dry or have a problem may say, hey, this is hurting a lot.
Yeah.
And you don't know until you go to look through your microscope at what you're seeing. So we do have a couple of patterns here for the staining that you might see.
Now remember, when they're looking at this with the slit lamp, you've got the blue filter on the slit lamp. Okay, so that's when you're looking at your staining with the blue filter on your slit lamp.
So once you describe.
So this first one here is just a little punctate keratitis. It's going to look like little black, little white dots actually breaking up in the fluoresce that's on the front of the eye. That's very indicative of patients who have dry eyes. And yeah, that's not a normal look for when you're looking at that tear film.
Some people who have seasonal allergies may have excess tearing, watering of the eye, and so they get these little punctate stains, as we call them. They just look like little tiny pin pricks in the eye. You may see just a few. This is diffuse on the eye. These are our like little pupils here. And it just looks like little teeny tiny dots.
Yeah.
And that is very, very common.
Yeah.
Now this second picture here, this can be indicative of anything that is, it could be an incomplete blink in the eye.
A Lego
it could be a nocturnal Lego where the eye doesn't close all the way at nighttime, or maybe during REM sleep they may have an opening. They could sleep with a fan. It could be somebody who has an ectropion where the eye just doesn't come all the way down. Or it could even be somebody who has a palsy where the lid just doesn't blink right.
It's just that exposure. It's just kind of an exposure thing of right where it doesn't completely close.
When you're at the slit lamp and you're looking at this, people really make sure that when the patient blinks that they're getting a good complete blink. Make sure that the eye's closing properly, that you don't have any excess lashes there. Sometimes when we look at the patient, we'll see 2 or 3 lashes that are hanging on the cornea going in the wrong direction. And when that happens, it can cause like a little microabrasion.
Yep.
Now the epithelium of the eye heals really quickly most of the time for most people. And so a lot of the times when they're coming in, they're always like, it's not as bad today, but we can see patterns that show this on the cornea with the fluorescein. And it's really important for what you see to communicate that with the doctor.
Yeah, you know, it doesn't take long to take a look at with the slit lamp. If you see those couple lashes that are growing in the wrong way, trichiasis, I mean, that's good to notate to the doctor. Go grab the tweezers, put it in the chart so that, you know, and make him aware that, look, this is going on when I saw the patient, and then you can take care of it in the room.
Now, the other day I had a patient that came in, her vision appeared to be normal, everything appeared to be normal in the eye, except she said occasionally she had a little bit of excess tearing in the right eye. And she had a really nice epi defect inferiorly, not centrally in her vision, and she was sitting there like, oh, this is nothing at all, and I'm looking at, okay. So you always you can draw what you see.
Oh, yeah.
Put it on a sticky note.
We're
Let
gonna
the
keep
doctor
doctor's
know.
attention,
Let the doctor know that he needs to put a little extra drop on there to take a quick peek at that eye. If you see something that is abnormal, communicate that. If
This one here is very indicative of what we would call a herpes keratitis. It's got little dendrites is what we call them, and in addition to some of the little punctate keratitis. So it's got those little viney little
bulbous, kind of almost at the end.
Yep, and you can kind of tell, and they can be anywhere. But the patient will have probably a scratchy irritation, sometimes painful, because it's disrupting that epithelial layer.
And that person needs special medication in order to heal that.
Yeah, it's not just an antibiotic.
The earlier it's caught, the better.
Viral. Yep.
Yeah. So when you do your pressure check, you always look with the full open beam of the blue light before you do your pressure check.
Yep.
And you want to do that to cover yourself as well, so that you don't end up
with something like this. This could be a corneal abrasion caused by too much pressure with your applanation tip.
Or cleaning your tip and then doing the pressure right away.
Where there's leftover fluid.
You don't want to give them any type of chemical abrasion.
Yep.
And so there are some people who, if they use the wrong drop in the eye, or it could be something that is toxic to the eye. A lot of women will use products on their eyes to help their skin with moisturizing, that type of thing, or even certain makeup removers. And they can leave a chemical keratitis on the front surface of the eye.
Yep.
Now, this one here is something that's very common with people who just aren't as experienced at putting drops in the eye and knowing that the lower lid, if there's a pooling of fluorescein that's thick there, you need to have the patient sit back and re-blot the eyes, but also keep in mind that their eyes are numb.
Yeah, exactly.
So people who blot the eyes too heavily, sometimes they can give themselves just sitting in the chair because they're blotting it or rubbing it, and they can give themselves like little epithelial disruptions just from doing that.
Yep.
And
really pay attention when you put that fluorescent. You know, we're going to talk about briefly checking the pressure, and you know, you put too much fluorescent in there, and this happens. You get way too much in there. Your Myers are going to be way too thick, and when they're too thick, you're going to have a lot lower pressure than they probably normally have. So you don't want that thick Myers when you're looking at them. If you see that, and you know, have them back off, have them dab their eye a little bit and get that amount of fluorescence down, and then take the pressure again.
Somebody who has too thin of a layer on the eye of the fluorescein, if the patient sits too long, or if for some reason you don't get to doing that pressure, or you are at the end of your bottle, and I call it sucking bubbles, when you don't get enough on the eye, then your Myers are a little bit too thin,
and then
your pressure is going to be too high.
Yep.
Once you learn optimally what is the perfect Meyer as to how it looks, keep in mind that then you're going to start matching the doctor when you're doing your pressure checks.
Go back and see what yours were compared to his. You know, that's a great learning tool, because once you get that consistent Myers, how you want them to look, your pressures are going to be way more consistent.
If you do a pressure check and you know your Myers were perfect and you back off, you have the patient blink again, always make sure you do your pressure check and back off if you have to do some sort of adjustment.
Yep.
And then come back forward again, come in contact with that tear film that has that fluorescein there. then you're going to have what we call a double check, and you can annotate that saying checked twice.
Yep.
Now, if the doctor gets something significantly different even after that, then you are talking about the patient could have been holding their breath. You could have been inducing pressure.
Yes, exactly.
But if you're not touching the eye and you know the patient's breathing, just communicate that, saying double check.
Yeah, if you get one,
no lid held.
Higher, no lid held, or if you get a pressure that's significantly higher or lower than what you've gotten in the past, that you've seen a pattern, take another one and annotate that, double check, or 2 readings same both times or something like that.
If you still feel that it was not an accurate pressure for you, grab a senior technician, pull them in and just say, I'm having a hard time getting a great pressure here. Let's have one more technician take a quick peek. We try not to touch the eye too much in the eye, but once you're at a point, if they're a complete exam where you have to dilate them, that can change things as well. So it's not uncommon to grab somebody else and be able to do a quick pressure check, because if you do it right, you can check multiple times without this happening.
Right.
If you're not heavy-handed, as you call it, make sure you know your slit lamp. And this. Know the normal. Because if you know what your normal is, then if you see something that's abnormal and you don't know what it is, and it's not something that's common, come get somebody.
Just look. It's such a great learning tool, and to get into that habit of, like you said, opening up that blue filter and looking first before you go in for that pressure, because then you're hopefully 9 times out of 10 you're not going to see anything, but when you do start seeing things, it's just really exciting to find it and then annotate that to the doctor so that he knows what you're looking for, and that will help his exam.
Something that I have seen, I've been doing this like 35 years now, and I've seen it at least once a year. It comes in very often. People don't understand, they have blurred vision, they do an auto, they have a hard time getting an auto, and they're doing a pressure check on them. The fluorescein doesn't look too much different, and it's a contact lens sitting on the eye. It's so much more common than people realize, where a patient has an extra lens there and they're completely oblivious to it because they've put a second lens on it, or they think that it's off, the eye doesn't feel, or it's red and irritated and they don't know why, and here they have a contact lens in, especially some of those seniors that wear contacts. So if you know what the normal is, that allows you to know the abnormal, so that you can communicate that to the doctor if something is abnormal.
So instead of doing an always and a never this week, we're going to do 2 always. You can do yours first.
Always communicate with the doctor. I'm a communicator, so I don't hesitate to write something on a sticky note to let him know. The more information the doctor has before they walk in the room about that patient, and it never hurts to put it on I'm a big fan of bright sticky notes, not the yellow that everybody's seen for years, but I always use some sort of communication just to let them know. Even if it's annotated in the chart, whether it's on a sticky note.
It might make a difference in his exam. If he feels that it's not, anything that's causing harm to the patient, that's fine. But at least you bring it to his attention.
Sometimes there are little foreign bodies on the front surface of the eye, so you don't get a green stain, you'll get a bright yellow stain. And so keep that in mind. If you see excess mucus, because fluorescein will have a tendency that mucus will pick it up and it'll mix with it and it'll look very stringy. If you see plenty of mucus in there, by the time the patient sees the doctor, they've done enough blotting from drops and dilation that a lot of times that mucus is gone. So, and you can rate that. Now the doctor is going to grade these. So he's going to put this in a trace 1+, 2+, 3+, 4+, and you can go back and look at those gradings and say, oh, that's what that one is.
And I saw that.
And that's a key tool for you following up, or even just asking the doctor, hey, what did they have?
Exactly.
So that you know. Now we have the luck of working with Dr. Ansari, who's a corneal specialist on top of being a general ophthalmologist. And so we see a lot more pathology on the eye. And so there's a lot more stains that are out there. There's just keep in mind that it's a diagnostic tool that is used by everybody to help evaluate and get that good exam to the doctor so that the doctor can make the diagnosis for the diseases and or problems that they're having.
One other quick thing before I do my other always is if a patient you know is coming in for an ulcer and we have not seen them before, before putting any kind of drops in the eye, I would always go ask the doctor, is this something you might want to culture? Do you want to do a corneal sensitivity test? I would just double check with them first because once you put the drops in, they can't do either one of those things at that visit. So just double check on that. My other always is just what we all been talking about the whole time is always look for your staining. Always look at your staining. What does it look like? Evaluate it. And like Rhonda said, annotate it.
Yeah, you never want to just put your drops in and go straight into doing your pressure.
And there's so much more to that slit lamp and that blue filter than, like you said, just taking a pressure. So
that's right.
So we hope you learned a few things today about staining and
see us next time on The View. And next month, I think that we have, or coming in the next few weeks, we have Dr. Kernan coming in to talk with some palsies.
Our next guest speaker.
Yeah.
I'm excited.
Yeah, it'll be very exciting.
All right.
Have a good day. Let's talk about ice more.